So I'm Matt Jones. I'm an orthopaedic surgeon specialising in hand surgery. I was asked by Laurie to come along just to tell you a bit about hands, really. So I presume you haven't got representatives from all orthopaedic specialties, so I feel like I'm quite privileged, really, to have the chance to tell you about hands. So I'll just tell you a bit about what we do, and then talk to you about why I think hand surgery is a good thing to do. So we treat lots of common conditions like carpal tunnel syndrome. You'll all have heard about that, entrapment of the median nerve in the palm, probably the commonest thing that we treat, and the commonest operation that we do is carpal tunnel release surgery. So just to point out a couple of things, so there's some wasting of the thenar eminence here compared to the normal side, and this is obviously supposed to be representing the median nerve going off to supply the radial 3.5 digits. So we do lots of carpal tunnel. It's quite a rewarding operation because it works really well, so you can make people better and they're really grateful for it. It's quite a quick operation, which means you can get quite a lot of them done in a day, and so you can help a lot of people in a short space of time. So it's quite rewarding from those points of view. This is just some slides demonstrating where your transverse carpal ligament is over the top here, encapsulating your carpal tunnel, and then you just incise through it basically, so the enclosed tunnel becomes a gutter, and that takes the pressure off. This is just looking down from above. That's your transverse carpal ligament, that white thing. You just incise down through it to open things up. Okay, we also treat trigger finger really commonly. So people often, especially patients, don't really understand what's going on with trigger finger. So essentially, the flexor tendon runs in a sheath from the tip of the finger down to about here, and then it runs in the open, and then it goes through the carpal tunnel, and then it runs in the open again and merges with the muscle. And the problem is here where it comes in and out of the sheath. That sheath gets a little bit tight, just here, then it rubs on the tendon. And as it rubs on the tendon gets irritated and swells, and you get this lump developing. And that just makes things worse, because that lump can't easily get in and out of the tunnel. And as it does so, it catches. And so people sort of make a fist and then they try and open their hand and they can't straighten the finger out unless they force it or they use their other hand to force it. So fortunately, we can treat this very easily with injections. So that works most of the time. It doesn't work so well in diabetics, unfortunately, and diabetics quite commonly get trigger finger. So the alternative is we can operate on it. And it's very similar to the carpal tunnel thing. You just open up the bit where the pulley is, where the end of the sheath is, and just slit it open. Okay, what else? We see lots of Dupuytren's disease. I've just come from doing a case very similar to this one, actually. So a genetic condition causing flexion contractures of the fingers tends to affect the little finger side of the hand more than the thumb side of the hand. More common in sort of 40s and 50-year-old age group. And it's really annoying because you can't get your hand straight, you can't open your hand. So it makes things like washing your face really difficult. Patients complain they poke themselves up the nose or in the eye. They can't shake hands with people because they can't get their hand open. They can't get gloves on. They can't get in their pockets. And I once asked a medical student, some of you may have heard this story, what sort of complaints patients may have if they've got Dupuytren's, what sort of things might they not be able to do? And this student said, oh, I don't know, I do buttons or fine tasks. And I was like, no, that's things where you need an open hand. And she said, doing high fives? I've still not had a patient come to me to say, the problem is, Doc, I can't high five. So I thought I had another picture of Dupuytren's. So there are a couple of things we can do about it. You can't treat the underlying genetic problem, unfortunately, yet. Maybe one of you guys will find the cure for us and put us out of a job. All we can do at the moment is relieve the contracture. So either poke a hole in the cord and snap it straight, or burn a hole in the cord with an enzyme and snap it straight, or actually unzip the hand and cut out the disease. Problem is, it comes back at some point. It will eventually come back because it's the patient's underlying genes that are the problem. Okay, we treat a lot of ganglia as well, so these little fluid-filled sacs that arise from tendon sheaths or from joints, quite commonly around the wrist. That's the most common place to get them. Most of them get better on their own. We can stick a needle in and suck the fluid out, and about half the time they don't come back, but about half the time they do, and you can cut them out. But then, of course, you're swapping a lump for a scar, and you can't guarantee that won't come back either. The risk's about sort of 1 in 5, 1 in 6 chance of it coming back then. So they're a bit of a nuisance, but again, quite a rewarding surgery. They're quite easy to get out. It's just disappointing when you see them 6 months later and it's come back. Okay, and we treat a lot of arthritis. So spot the difference. We've got a missing bone here, so the trapezium bone at the base of the thumb here. There's loads of arthritis, all this white fluffy stuff and loss of joint space around the base of the thumb here. That's giving the patient lots of pain. And so we can remove that bone so that the thumb metacarpal's not got anything to rub against. And that works quite well, especially in older patients. So we see quite a lot of that. It's probably the commonest or second commonest place in the hand to get arthritis after the DIP joints. But it's probably the most common place where we need to treat arthritis, because DIP arthritis isn't often that symptomatic. Okay, and then we do clever stuff. This is probably more the plastic surgeons, because hand surgery is a combiner. It's a bit of a grey area. It's a bit of a no man's land between orthopedics and plastics. So you can become a hand surgeon by training it through the plastics route or through the orthopedics route. This sort of thing is usually done by the plastics, but orthopedic surgeons do as well. So as you can see the picture on the left, this is a child. They've got a radial longitudinal deficiency. So if we had x-rays, their radius would be deficient. They're clearly missing a thumb. And the thumb is obviously really important. So you need to try and do something about that, otherwise the hand function is going to be terrible. So in this case, you can see they've taken the index finger and they've rotated it around 90 degrees and constructed it into a thumb. It's called the policization, thumb being policization. The other thing you can do is start taking toes and stuff and putting that on the hand, but that involves violating the foot, and who wants to go down there anyway? So yeah, so policization works well. Patients really work well with 3 fingers and a thumb. You don't really need 4. And in fact, if you're ever in a hostage situation and the terrorists are planning on chopping off bits of your body and sending them back to your relatives before they, so they can get a ransom, if they offer you the choice of which finger to chop off first, offer your index finger, because you really don't need your index finger. Your middle finger does a really good job of being an index finger if you haven't got your index finger. So let them have that first. Don't let them have your thumb. Okay. Oh yeah, and we do really nasty stuff as well. So fortunately, we don't get too many things like this. But both bony and soft tissue trauma makes up probably a bit more than half of our workload, especially at UH, because it's being a major trauma centre. So we get quite a lot of hand trauma. Most of it's nothing like this. Normally it's kind of individual isolated fractures or isolated tendon lacerations, people trying to stone an avocado and stabbing themselves in the hand. So my first avocado injury was a Warwick medical student. We've had probably 6 or 7 since then, but that was the first one I came across. I thought it was just you guys, but apparently not. It's people out there. So it's normally isolated trauma, but yeah, sometimes you get nasty stuff. And the basic principles here are just kind of clean it up, remove anything that's dead or devitalized, see what you've got left, and then try and make the best of what you've got left. You might want to start bringing in other materials from, tendon grafts from the leg or nerve grafts from the leg. You've got other places you can go, but it's what have you got, what do you have to get rid of, and then what do you need to reconstruct to get the best function. Okay, and we do bony trauma as well. So this is a case of a patient who had a distal radius fracture, who was treated or not treated in a different hospital and ended up about a year or so down the line with a lot of pain and stiffness in his wrist because his radius had healed short. So we opened him up, cut his radius across here, jacked him out to length, restored the shape of the radius and put this artificial bone graft stuff in the gap. And so we tried to reconstruct the shape of the radius and hopefully that'll improve his function. And this is another cool one. So this is a guy who was using a circular saw and kind of slipped and gouged a big chunk out of his proximal phalanx of his thumb. So we kind of scraped all that out and fixed it with what we had left with some metal plates. And he did well for a while. And then his thumb started to kind of bend over to one side gradually over time. And then he developed a bit of a sinus and started discharging stuff. So he had some infection there. So we had to open it up, scrape it all out, wash it all out, put some cement in the gap here, so there was cement here originally, and then put this external fixator on, so 2 pins either side there, and then there are bars connecting this, but you can't see them because they're made of carbon. And then 6 weeks later came back, took the cement out, put some bone from his hip in the gap, left the frame on, and hopefully what should happen is that bone should integrate with the bone that's already in the thumb. So fingers crossed. The problem is he's a heavy smoker and he won't stop. His smoking interferes with bone healing, so he's not meeting us halfway. But we'll see how that goes. So why hands then? So this is probably the most interesting bit, I think. So I suppose I chose hands because I think that hands are really important. I'm sure you'll all agree hands are pretty important. In fact, we joke in orthopaedics that all the other specialisms, all the other parts of the body are simply there to position the hand in space. So not only the shoulder and elbow, but the feet, so you can walk over to do things. So hands are really important. And therefore you can make a big difference to people, especially with trauma. You know, if somebody cuts the tendon, well, their finger's never going to work again unless you reconstruct it, and if you do, then it works really well, usually. Patients with carpal tunnel, you know, carpal tunnel seems like, you know, it's really common and you perhaps don't think of it as a very important condition, but actually it's really, really sort of life-destroying, because patients wake up several times in the night with pain in their hands. They have to shake their hands out so they don't sleep, so they don't, you know, they don't have very good waking hours because they're tired all the time. So it's really quite disruptive. So it's great to be able to do something about that. As I said at the beginning, many of the operations we do in hand surgery are quite quick. So the carpal tunnel, the trigger finger, you can actually get quite a lot done in a day and help quite a lot of people in a short space of time. They're not all quick though. So the case that I've just finished doing was just over 2 hours. That was at Dupuytren's. So there's plenty there to stimulate you. It's not all just banging out quick operations. There are complex ones as well. I think the anatomy is really stimulating. So I could never really make out anatomy of the abdomen. It didn't make sense to me when I was trying to learn it. It's just all a jumble of stuff. Whereas in orthopedics, stuff's going from one place to another. It's like a roadmap. You know, you've got a start and a finish, and you know, you've got something linear in between, and I could get my head around that. So that kind of led me into orthopedics, and it's the same in the hand. Everything's going from one place to another and has a function. So I found that really useful and interesting. And it's all quite fine, of course, which is interesting and challenging. There's lots of different stuff to do. You've got it's the same with other orthopedic specialties. You've got the trauma as well as the elective stuff. And there'll always be people cutting their hands, stoning avocados. There'll always be people crashing their mountain bikes. There'll always be trauma work to do. So, you know, even if we do find a cure for Dupuytren's, hand surgeons will still have plenty to do. And orthopedic surgeons have plenty to do, even if they find a cure for osteoarthritis, because people will still go and crash their motorbike and crash their car and all that sort of stuff, fall off ladders. So, so it's varied. There's plenty to do. There's all the orthopedic side in hands, but also the plastic stuff. And although you can train through either route, there's quite a lot of crossover. And usually when you get to the top of your training in either route, you do an interface fellowship. So you do a fellowship for a year where you do both orthopedic and plastic aspects of hand surgery. So you kind of learn the bit that you didn't know already, so that hand surgeons can be kind of dual trained. And actually the way hand surgery training is going in the UK and the rest of the world is that hand surgery training will start at an earlier stage, and rather than train in orthopedics or plastics and then specialise later, you actually specialise in hand surgery from an early start, and you learn all the orthopedic and plastic stuff all the way up. That's not here yet, but that's what the Hand Society in the UK are trying to promote, and they're quite a powerful group, so I think it will happen. You get to sit down to operate. That's always a joy, especially if it's a 2-hour operation. So I think that's great. So sit down to operate, sit down to pee is what some people say, which is a bit mean. Sit down to operate, sit down to eat. It's much more civilised. And it's the same when you're in clinic as well. So unlike the foot and ankle surgeons, where they have to keep getting up and shuffling around, looking at feet and stuff, we can just sit opposite the patient and, you know, just examine their hands. Very easy. It's very easy to expose the hand because it's usually exposed anyway, and just roll the sleeves up. You don't have to take their trousers off or anything like that. So it's all very easy to consult and very civilised. I've put, you're operating magnified, so failing vision is mitigated. So I think if you get older, if you're a surgeon, as you get older and your vision starts to become a little bit not as good as it was, then that I think can be a bit of a challenge. I like to think it's probably less of a challenge in hands because you're operating with magnifying glasses on anyway, so you just get more powerful magnifying glasses. Nice colleagues, that applies across orthopedics actually. Orthopedic surgeons traditionally have had this kind of, I don't know, sort of jockish reputation, which I don't think is deserved most of the time. There might be the odd one, but most orthopedic surgeons are a nice bunch, and it's part of what drew me to orthopedics. And then within hands, they're a nice bunch as well. In fact, I think they're a nicer bunch, and that's kind of what led me to it. And actually, it's sort of joking aside, you'll sort of realise as you go through that different people get drawn to different specialities, and you'll find that you get on with, say, the liver surgeons better than you get on with the spine surgeons or whatever. And I don't really know why that is, but like people tend to kind of gravitate. So if you find a group of doctors who you get on with, or you think, oh, you know, I think I'd get on with them, then that's probably as good a reason as any to start sort of heading in that direction, because you'll probably find you'll get on well with your colleagues. And actually, you'll probably enjoy whatever work you do, but getting on with your colleagues is probably more important. And yeah, we do cool stuff in orthopedics and in hands, and I've showed you a couple of examples. So, very happy to take questions on hands or orthopedics or whatever, life in general. John asked me. You can get me back if you like, Imran. You can ask me a question.
So, did you train, I assume, in orthopedics?
Yes.
Did you think it was did it do you a disadvantage not doing plastics or at an early stage?
It's a good question, because I almost had the opportunity to do plastics at an early stage. So I was caught up in the MMC, MTAS thing when that was going through initially. And the sort of the first 2 years of my orthopaedic specialty training, so ST1, ST2, there were 2 programs, and one of them had plastics in and one didn't, and I prioritised, I put the plastics job down as my first choice, but I didn't get my first choice. So I would have done some plastics early on, and at the time I did think it was important, and I still think it would have been useful actually, because there is a lot of crossover between orthopaedics and plastics in hand surgery. So I think having done some earlier probably would have helped. Yeah, go ahead.
What's been your, it's a kind of big question, but what's the most kind of gratifying case you've ever worked on?
Okay. I don't know, I feel like I'm in an interview now. Okay, so about a year ago, there was a guy who had come off his motorbike, whacked his arm on a car in the process. Seemed to be like a direct blow type thing, because he's managed to break pretty much every bone from his fingers up to his humerus. I don't think he broke his humerus, but he broke everything. He broke his ulna in like 3 or 4 places, his radius in 2 places, several carpal bones, several metacarpals and phalanges. And he had had a couple of open wounds as well, so he had open fractures. So he was at high risk of losing the limb. He was at high risk of getting osteomyelitis, so infection in his bone. But because of all the surgeons that were involved in his care, he had proper care, he had prompt care, lots of operations. He hasn't lost the limb, he's got a functioning limb. He didn't get bone infection. His x-rays look really impressive. I wish I had them with me, because he's got like loads of plates everywhere down the arm. And yeah, he's really stiff. He was always going to be really stiff, but his fingers work pretty well, so he can use his hand. And he's really pleased. He's really a nice bloke as well. So he's really, I suppose it's the most grateful patients are the ones that are the most gratifying when they come in and they're saying, oh, thank you so much. It made such a big difference. So I think he's quite a good example of one of those patients.